Hey, so we're going to talk about chest pain, and we're going to be concentrating on cardiac and visceral causes of it in this particular snippet. It's worthwhile always having cardiac problems in the back of your mind when the patient complains of thoracic pain. Now, this is particularly true when the pain is anterior and less so urgent when it's posterior. But in either case, this should always be something in your head. So what we're going to do today is look at trying to differentiate out those that we should be treating and those that we should be basically sending to the emergency room. And I hope this does that. I don't want to get you overly paranoid about this, but I think, and there are some fairly simple ways of doing this that doesn't rely on electrocardiograms and so on. So let's see how we do. Looking at the tissues that may produce chest wall pain, got the heart, the covering of the heart pericardium, esophagus, lungs, pleura, aorta, diaphragm. All of these can give you chest pain that isn't related to the locomotor system. Well, essentially, the heart is locomotor in as much as it supplies blood vessels to it, but I think you know what it is, musculoskeletal vascular systems. So let's look at the stuff that is present that will make you worry about this. And as I say, most of this stuff is about anterior chest pain rather than posterior chest pain. So there is one on there that I haven't put up there, and that's visceral type of pain. If this pain is dull, deep, diffuse, achy sort of a pain that isn't musculoskeletal in nature, then assume that it is visceral. It's probably not cardiac, but it could be almost any other viscera. So go with that and refer it out. That having been said, the stuff that are positive indicators is anterior substernal pain. So it tends to be a chest ache across here. It tends to be rather a sharp pain unless you're actually having a myocardial infarct with ischemia, a dull pressure pain or heaviness. But remember that if there is a myocardial infarct, this can become extremely acute and sharp. Unlikely that you'll see that though, simply because this is the thing that sort of happens before they collapse. Unless it's actually up in your clinic, you're not going to see this either as a walk-in or as a referral. Pain that radiates from the chest to the neck, jaw, and either or both arms. Now it's interesting, the left arm isn't the only arm that gets affected with heart problems. Both arms can easily be affected. The pain increases with general exertion. We're not talking about moving your thorax around now. This is general exertion, walking fast, walking upstairs, and so on, that isn't specific to the thorax. It's about what you would expect. This is a demand ischemic pain. So when you demand more blood, this happens. Now, that doesn't always happen. It's possible to have this pain at rest, which is also not great for us. We don't expect to see pain at rest with a musculoskeletal problem. So either one of these two, pain that's increasing with exertion, decreasing with rest, general exertion now, or pain at rest is not really what we want to see here at all. Postprandial pain, they eat and the pain comes on after that. Now this is almost certainly more of a visceral pain, probably esophageal, probably subdiaphragmatic, possibly subdiaphragmatic, but this is more likely to be a visceral problem rather than a cardiac problem. But either way, you don't want to mess with it. Pain on bending forwards from the hips. This is again usually esophageal or gastric at least. And then you've got breathlessness, diaphoria, hypertension, tachycardia. These things are also called cardiac equivalents. Instead of having angina, some people will have these symptoms. Now, you've also got typical and atypical cardiac symptoms. Atypical apparently is going out of favour now, not that I really care. It's called non-cardiac, but even if it is cardiac, I think that's probably more misleading than atypical, but it's not my problem, it's their specialty. But women in particular and older patients tend to have completely different presentation from the younger patients. So most of these people that are going to come in and have this non-acute episode, basically are going to be between 55 for men, over 55 and over 65 for women. And older people and women have this atypical presentation. It's worth keeping that in mind. Not everybody gets pain down the arms and substernal pain. So for women, this can be, and older men actually, can be fatigue, nausea, vomiting, just general lethargy. So this is what we finished up on the previous slide and more specifically now. So these are less positive indicators, and as I say, they occur more commonly in women and elderly and the elderly. The one argument for this is actually it's not specific to women, but it's more specific to elderly people. Because women live longer, they tend to produce these problems a bit later on in life, over 65, whereas men it's over 55. So this may be an elderly thing rather than a female thing, but either way, it doesn't really matter. But fatigue, nausea, vomiting, sleep disturbances, type 2 dizziness, nausea, lightheadedness, wooziness, and so on, and anxiety. Now, remember that you're not seeing them for this. They're coming in not because they're tired, but because they've got a pain somewhere. So this could be happening at the same time as they're coming in for a different musculoskeletal pain. So it's worthwhile taking notice of this. And of course, what you don't see is as important as what you do see. So anybody complaining of pain, actually anywhere now, posterior or anterior, that is unrelated to trunk movements or postures. The PAs are negative. You can go down and do PAs all up and down the spine and there's no response to them. Anteriorly, there's negative tenderness over the contrasternal area, and they've got good pain-free range of motion. So these are all things that you would expect to be positive if this is a spinal problem or a costal problem, a costochondral problem. So if you're not finding this stuff, then you have to wonder what the hell is going on. May not be cardiac, but it's unlikely to be musculoskeletal. So again, same thing again, because it's in the chest area, push them to the emergency room rather than back to their physician. Okay, this is the cardiac decision rule, and it's used in the emergency room. And basically, the argument is that 3 out of 5 of these things being positive would initiate a cardiac routine where you're going to run in and start doing stuff. Now, in practice, anybody coming with chest pain is likely to have an EKG, troponin tests, and so on. But get in there, this is the cardiac decision rule. So any patient 55 or 65 in women or older in these two areas, there's a known history of cerebrovascular disease or previous cardiac problems. You can't reproduce pain by stressing the musculoskeletal system, as I said. Range of motion loss is not there. PAs over the spine, tenderness for the anterior chest around the costochondral junction, tenderness along the ribs just in case there was a pathological or stress fracture there. The pain is worse during exercise and it improves with rest. And the patient is anxious that this is actually a cardiac problem. Now, if this one is positive, you have to wonder why they're in your clinic worrying about it when they really should be in their doctor's or the emergency room. But 3 out of 5 of these would lead to an identifying this patient as having a cardiac event. And then they will prove it with testing. Now, this is actually quite a useful test, this decision rule. If you look over on the left side, you can see the sensitivity of this is about 0.8, about 87%, specificity about 81%, which gives you a likelihood ratio of somewhere in the region of about 5 and a negative likelihood ratio of 0.16. Now, it's a positive likelihood ratio that's important because you're looking really at sensitivity here. But if you look at post odds on this with the prevalence, if I remember right, is somewhere around about 7%, then the posterior odds, when you apply this decision rule to the prevalence of heart attacks in the general population, the odds now hit 8 or 9 to 1 of them having a cardiovascular problem there, heart problem. And the posterior probability, if we change it back, is now 89%. So this is really quite a good rule, and it's probably worthwhile you paying attention to it. At the same time, what you really should be doing with these patients is looking for hypertension, tachycardia, breathlessness, extreme swelling, and so on. The signs of this, you should be doing this, and these are called the equivalents of angina. So the assumption is when a patient walks into an emergency room that they do have a heart problem. That's a basic assumption they work from, and they disprove that. And this isn't the worst thing in the world to do. Now, this is exceptionally true with anterior chest pain, and less so with posterior chest pain. But it's worthwhile looking at those questions, and it's absolutely, as a screening test before you even start to examine, do PAs on the thorax, see if you can reproduce the pain there. If it's an anterior chest, look for the tenderness over the costochondral junctions, which should be osteochondritis. And if you think there's a fracture, palpate carefully along the rib, looking for that tenderness. So heart problems is a big issue here. Everything else the patient can survive, but if they're in the middle of a heart attack and it's not an acute myocardial infarction, as I say, you're not likely to see those, then do yourself a favour and refer this out. You're better off, again, being wrong the right way. All right, guys, take care, everybody. Bye-bye.